Hi everyone, I'm Ann Peled. I'm a breast and plastic surgeon in San Francisco and wanted to talk today about a bunch of issues related to breast implants, mastectomy, and breast reconstruction. So for starters, I recently wrote a blog about this for any of you who want to read it or check it out to hear more about what's been going on in the news with breast implants. So as many of you may know, there's been a lot of information out in the media right now. The FDA recently held hearings in late March about breast implants, and I think there's a lot of misconceptions about it right now. So sort of for starters, I think one of the most important things is that as plastic surgeons, we are all really interested, concerned with any symptoms, anything that you have that may be going on if you have breast implants already. So definitely if there's anything you're worried about, call your plastic surgeon, come in. We're happy to see you, happy to talk to you about it and make sure that you're comfortable. I think the next important thing to know is that no one is recommending that your breast implants come out. No one is suggesting that this is going to be a solution for women who may be experiencing certain symptoms. We don't know if this is going to help or not, but there's definitely no recommendation right now that breast implants are unsafe to have in your body and should come out. So again, if you're feeling like your breast implants may be causing you symptoms, I think it's really important to have an honest discussion with your surgeon about that. And then the final thing I think is really good to keep in this context is that many women have breast implants for augmentation or reconstruction and do great with them. So I think it's really hard not to get concerned and caught up and panicked when you're hearing all this information. But I think, take a deep breath, know that most women do fine, and then try to educate yourself about the implants you have or the implants you're considering, and know that fortunately we have lots of different options, and you can find one that makes the most sense for you. So again, feel free to check out on my website on a blog about it I recently wrote if you have more questions about what we know, as well as resources from the major plastic surgery societies, as well as the FDA about breast implants. So I wanted to move on to some questions that I've seen online recently about breast implants, breast reconstruction. These are some commonly seen questions that I hear from women who may have talked to other surgeons about safety, and thought these would be good to address. So one of the first ones is about women who choose to save their nipples and how many of those women end up getting cancer, either if you have your mastectomies for prophylactic reasons or you have them for cancer reasons. And I think fortunately, we have a good amount of information out there now about nipple-sparing mastectomy. And we know that as long as you're actually taking the ductal tissue inside the nipple, so you're leaving the outside, but you're taking the ductal tissue inside, that you're not at increased risk for cancer. If you already have cancer, you're not at increased risk for it coming back. So I try to tell people this often. I think there are very few reasons we can't save your nipple for either prophylactic or cancer reasons, unless, of course, there's actual cancer in the nipple itself. Other questions about nipple-sparing mastectomy, I hear people say that their surgeons are worried about the risk of necrosis, meaning that their nipples might have healing problems or some of the nipple tissue might not survive. And again, fortunately, over time, surgeons that do a lot of these, centers that do a lot of these have really evolved so that the chance of true nipple necrosis, meaning you have healing problems where your nipple can't be saved, can't heal, or loses projection, is really low. So I think this is the time, if you're thinking about this, seek out breast surgeons who have additional training in breast surgery to specialize in nipple-sparing mastectomies, and ask them realistically about options for you to have nipple-sparing mastectomy. Sometimes we have to get creative and do things like a breast reduction or a breast lift first, get everything set up, and then come back and do the prophylactic mastectomy or the mastectomy for cancer. But that works really well, and it's a great strategy for saving the nipple. Other questions I get is sort of what to expect from a recovery standpoint for prophylactic mastectomies or mastectomies for cancer. And I think a lot of it really depends on what kind of technique is used, and how big you might be, and whether or not you're doing reconstruction with implants or with your own tissue. Certainly doing reconstruction with your own tissue is a bigger recovery. One of the reasons people sometimes choose that is because long-term, they may be less likely to need revisions or more surgery, but in the short term, there's a much bigger recovery. So I tell my patients thinking about having reconstruction, such as a deep flap using tissue from your abdomen, that they should really think about it as a 6-week recovery. So the first 2 weeks, you still have your drains in place. Your abdomen is kind of uncomfortable and you're not feeling like moving around very well or very often. After 2 weeks, from about 2 to 4 weeks, you start getting to move around better. You're walking around, doing lightweight stuff around the house. And then between 4 to 6, you can slowly get back into activity, exercise. And by 6 weeks, most people feel pretty good. You may still be a little bit swollen, but I think most people feel like they can get back into most of their life. I think physical therapy can be hugely helpful if you're recovering from flap surgery. It's a big area to heal. They can help with lymphatic massage. They can help get you strong, help you with your core, which can be impacted after flap surgery. So I think it's good to really involve a physical therapist. When we're thinking about implants, the recovery is certainly shorter because you don't have another incision or another donor site to heal. If you're having expanders or implants that are going over the muscle, I would say by 2 weeks, which is usually when your drains come out, you are feeling pretty much back to normal, certainly still a little sore, a little tight, but by 2 weeks, once the drains are out, you can start doing things like an exercise bike or an elliptical trainer, no arms. And by 4 weeks, you can get back to pretty much most activity, except stuff that really activates your pec muscles. So push-ups, plank, things like that. And then by 6 weeks, most people are back to whatever they want to do. So to be honest, from a work perspective, I usually tell people if you're having implant-based, meaning either an implant or an expander, mastectomy, reconstruction, probably by 2 weeks, once your drains come out, you're going to be fine to go back to work. And many women are working from home if that's an option, even that second week. So I'd recommend giving yourself 2 weeks because I just think it's nice not to have anyone who's relying on you or counting on you and let you really focus on yourself and healing those first 2 weeks. But I do think it's very doable to go back to work after a couple weeks. Other questions that I have on here is sort of thinking about what your options are if you have large breast but kind of a small frame and don't have great options for using your own tissue. And I think that is a really challenging situation because the way that we pick implants, we basically base them on what's called their base width. So when you're looking at an implant, there's a certain measurement across the bottom, and you can't put in a huge implant in someone with a small frame because their implants will be out the sides and their body just can't support enormous implants. So I think if you are someone who's small, doesn't have a lot of extra tissue to use for flaps, and you want to have implants, it's good to really have a discussion with your surgeon about kind of what is the largest size you could realistically be and still be able to support the implants, have them match your frame, and then decide, is that size, if it's a lot smaller than you started, is that something that is realistic for you that you could be comfortable with? The other thing to think about is that if you're going to have a nipple sparing mastectomy and you're going to end up a lot smaller, you do need some kind of reduction of your skin to match your new breast size. So that's when we start thinking about doing that breast reduction as your first stage and then coming back, doing the mastectomies and your reconstruction at a later date. Other questions are asking about gummy implants deflating. So I think one of the things that we're really lucky with in the world of implant technology right now is that we have these great so-called gummy implants that are highly cohesive gel, meaning that the gel in it is nice and firm, although they still feel soft and natural. You don't have to worry about it opening up, spilling out anywhere. You can actually cut them with a knife and the implants don't go anywhere, which is really great and is a huge step forward in implant technology. One of the things that can happen though, especially with bigger implants that are what we call kind of higher profile, meaning they kind of have more of a shape like this, what can happen is that sometimes those implants can flip around so that the back of your implant is on the front and vice versa. So sometimes when I see people asking about, has their implant deflated or ruptured, what's actually happened is that the implant has flipped front to back. Wonderfully, there's an easy fix for that, which is to actually remove it yourself in the pocket. There are actually some great videos online on YouTube of women doing this at home. And so you can actually, without needing more surgery, without needing anything particularly painful, when you're at home, flip it back in. Often you do this once or twice, it doesn't happen again. Rarely do you need to actually go in and have a surgical solution to make the pocket tighter. So if this does happen, certainly always a good idea to talk to your plastic surgeon if you notice a change in your implant so that he or she can take a look and make sure that that is what this is and not something else. But truly most of the time with these gummy implants, it's not a deflation or a rupture problem. It's really just a moving around in the pocket. And then finally, one of the other questions I get is thinking about how you choose implant size. So I would say that this is pretty tricky for reconstruction to really get a good sense of what size implants you might need and kind of how you might look. So for breast augmentation, we have really great ways of doing this. We have 3D imaging technology we can use. I love it for my patients. You can actually take your own pictures and show what you would look like with adding in 200 cc's, 300 cc's, and give women a real sense of how they look with an augmentation. I like to actually use this technology for my reconstruction patients as well. And it's nice because you can show what you would look like with the added volume, but it's hard to translate that into actual implant cc's because you're going to be removing the breast tissue and then basically putting it back and whatever you want to add on to it if you do. So I would say definitely a couple options for trying to figure this out. One is 3D imaging. I do think that can be helpful. And then the second thing that I really like is some of the implant companies I happen to use, Allergan with Nitrel, they have what's called a consultation kit that actually have temporary implants that look kind of like implant shapes that you can put into your bra and see what you would look like. So those can be great for augmentation and reconstruction and might be a good thing to think about if you want to know what you might look like. I'm just looking at a question that came through. I just got to ask a question about seeing redness at incision sites where you're not looking like you're infected, but you do have some redness. So I would say a couple things about that. One is that sometimes it can just be irritation and inflammation around the sutures that are deep underneath your incision. So some people do have a bit of a reaction to suture material, and they're not going to reject it or spit it out, but what they can happen is just have some redness along the incisions themselves. And that can some people take a good several months to resorb. The other thing to think about is that the matrix that we use, which is a skin substitute, the most common one is Alloderm, but there are other ones as well called ADMs. And what can happen for some women is it's something called red breast syndrome, which is basically in the area where the Alloderm or the ADM is, women can have some redness of their skin over that area that can kind of mimic infection, but really isn't one. And it's not permanent. Again, it's sort of a bit of an inflammatory response, but then that goes away. So I think to answer your question, that would be my main thought would be this is either sort of a reaction to sutures or a rare but not concerning response to the Alloderm, and both of those would be going away. So I had one last question that was thinking about traveling after breast reconstruction surgery. So breast reconstruction is obviously a broad topic and it could include several different things. I think one thing to think about is how long your flight's going to be and concern about blood clots. So definitely if you are taking a flight that's going to be more than a couple hours, if you've had any surgery within the last, honestly, 6-8 weeks, or you've had a history of cancer, I recommend getting up often. I think that we all see how our legs swell if we're sitting on flights, even if you haven't just had recent surgery. So I would say every hour or two, just get up, walk around a little bit, stay well hydrated. And I think that's just good practice to do in general. I also like to wear compression socks when I fly, and I think it's a good recommendation for anyone. I think that you'll find after something like an implant exchange or fat grafting, which is basically liposuction from a site, that you'll feel pretty good to fly after about 10 days to 2 weeks. The one thing that I worry about with people is the suitcases up overhead. So certainly that's something that I would say in the first 2 weeks, if you could avoid that, that would be really helpful to try to get someone else to do that. After 2 weeks, if it isn't your first stage and it's an exchange or another revision, I think it's very reasonable to do most things. So I know, always talk to your own plastic surgeon because some people might say longer than that, but I really think for many smaller procedures, 2 weeks is very reasonable. Anyway, it's been great having all of you. Please feel free to check out the website for more information. Thanks.